We are here at our Orange County Mattress Mission Viejo location today, and we have a very special guest, Dr. Aimee. I want to get it right, so I'm going to read it here. Dr. Aimee is a diplomat of the American Board of Dental Sleep Medicine. Dr. Aimee graduated with a Doctor of Dental Surgery degree from the Herman Ostrow School of Dentistry at USC. She then completed a 2-year intensive general practice residency at the VA Sepulveda Ambulatory Care Center, treating our nation's heroes. Please welcome Dr. Aimee.
Well, good evening, everybody. I'm Dr. Aimee. I'm a dentist here in Orange County, right here in Mission Viejo, and I treat patients with snoring and sleep apnea. Probably wondering what the heck a dentist has to do with sleep apnea. Traditionally, patients know and associate sleep apnea with a CPAP machine. But what you don't know is that for patients with mild to moderate sleep apnea, we are considered a first-line therapy. The CPAP machine is great, treats everybody wonderfully. It can be used for mild, moderate, severe, but so can our appliances. An appliance is used for keeping the airway open, and it works very much like orthodontic retainers or night guards that people are familiar with. This is one type of appliance I use. It is an upper and lower tray, and it has 2 fins right there which help hold that lower jaw forward. That allows the tongue to not fall back into the back of the airway and keeps the airway open all night. Let's backtrack a little bit. What is sleep apnea? Obstructive sleep apnea is a chronic condition in which the upper airway collapses, partially or completely collapses at night. So when you go to bed at night, you rest, you lay down, fall asleep, drift off into sleep, your body turns on the parasympathetic or the rest and digest nervous system. That relaxes your muscles. It should be putting your blood pressure in a nice low, relaxed, and you start to go through your stages of sleep, 1, 2, 3, and your REM sleep. But what happens is that as you relax, the tongue can fall back, soft tissue in the throat can actually collapse. And what that does is that actually closes that upper portion of that airway to the point where you either have a reduction in the blood oxygen level or you completely stop breathing. For which point your brain gets a buildup of carbon dioxide. That then triggers your brain to say, am I going to continue sleeping or am I going to breathe? It's always going to pick breathing, and what it does is it triggers the sympathetic or the I saw a bear fight or flight response, turns on, tones all those muscles back up. You take a big deep breath and you start to breathe again. Everything tones back up, everything's good to go. Then you drift back into that sleep, and it happens over and over again. Patients can have that anywhere between 5 to hundreds of times a night, or hundreds of times at an hour actually. And so that causes disruption in normal sleep patterns, and repeated time spent below 90% oxygen can also cause less oxygen to the brain, so people complain of foggy memory, put you at higher risk for stroke, heart attack, headaches, morning headaches, that's a big one with females. Men and women display stuff a lot differently. Everyone's seen the poster boy for men. It's the overweight man over 50 who's diabetic, high blood pressure, and snores like a freight train. That's not usually the women. The women I see are more the slender, long history, TMJ pain, headaches, and can have signs of anxiety and depression as well. So they don't display the same. Females tend to get diagnosed a lot later and more severe in the process because they explain it away with lifestyle and just the stresses of normal life, whereas the men usually, the wife actually brings them in saying they snore like a freight train, they're stopping breathing. You know, I see them die every night. So they come see me. Usually how it works in our practice is that you're screened in the hygiene chair actually. So most patients that come see me from the get-go haven't actually been diagnosed yet. Some are intolerant to CPAP, some haven't been wearing it for years, some have been on an oral appliance and it doesn't fit anymore, but a lot of them just don't sleep well. And so when they come in, we have an in-depth conversation about their signs, their symptoms, which can be anything on here. Snoring is a big one. 50% of men snore, while only 25% of women snore. Even if it's not full apnea, it is a resistance in the airway and it should not be happening. It's very common, it's not normal. So it's definitely something to take a look at. Other stuff is anxiety, depression, morning headaches, like I said, diabetes, AFib's a big one. So a lot of cardiovascular stuff puts you at high risk for sleep apnea. So you come in, you talk to me, and the way it goes is, for the most part, it's accepted that for patients with mild to moderate, either the CPAP or the oral appliance can be first-line therapy. For severe patients, myself included, I want everybody to try the CPAP first. We know it has a high success rate, it's 100% effective, but it lacks some compliance in terms of patients wearing it. So that's usually the route of action. Mild to moderate, you can try either, and severe usually has to have a CPAP trial first. So what usually happens when you guys come to see me is when we're all ready to go, we have a diagnosis of sleep apnea, ready to go for an appliance, you come into my office, we do a dental exam. From there, it goes off to the lab about a couple weeks later, usually 3. You come back in, we deliver the appliance, get you all ready to go, and we send you home to get used to it. Takes most patients about 3 weeks or so to get used to the appliance. If they've worn retainers, night guards, stuff like that, it's a lot easier. But you get a little extra salivary flow, you've got some soreness because now we've taken that jaw and moved it slightly forward. But for most patients it's very mild and usually goes away within a couple weeks. From there we use a little airway monitor and we use subjective feedback and we then start moving that device forward into further incremental portions to get it to the point where we have subjective and objective relief compared to a patient's baseline. When we feel like we've got the best position, we then get our report back together, and we actually send everything back to the MD, because the MD is the one who's actually treating and managing the disease. I'm treating the device. Since I am a dentist, I cannot treat the actual sleep apnea. So that's usually how it works with oral appliances. As Stephanie introduced, I did start doing this back in the VA. My lifelong passion was actually to be a general dentist. When I was 10, I broke my jaw, and from then I knew I wanted to be a dentist. But once I got to the VA and I started seeing what these appliances were doing for patients, and I didn't learn about this in school, it sparked my interest. So after school, went out into the world and did my general dentistry and started doing these classes over and over until I finally decided that this was something that I wanted to get involved with and do permanently. And this is all I do now. So I have a passion for sleep. My mom was diagnosed 4 years ago, I think now. Has been a loyal CPAP user since then. She had severe sleep apnea. I've had my dad tested. My daughter has sleep disordered breathing, negative for sleep apnea, but it's around my husband's family. I mean, everywhere you look, there's 52 million people walking around just in the US alone. 1 in 5, I think, has mild, and 1 in 15 are severe sleep apnea, untreated diagnosed patients. So I just felt this calling to go out and help people sleep, because not sleeping when you had an infant was terrible, but that was only fleeting. That was 3 months, something like that. But these people go years and years and years without sleeping. And so if I can help a couple people sleep better, then my job is done. So if you're tired of being tired, come on down and see me. I'm right here in Mission Viejo, and I'd love to help you sleep better.
So thank you, Dr. Aimee,
You're
for
welcome.
being here. I do have a few questions for you.
Of course.
So the first one is there a type?
Yes and no. So men are more predisposed. There's a questionnaire that you can fill out, and it's, are you this? So men over 50, obese with diabetic, and a neck circumference over, I believe it's 16 inches, are higher risk for it. But women are just as much at risk. It not only, it's an anatomical problem, but it can also be non-anatomical features. So it's how your body responds to the stresses of airway collapse, and it's almost like the faulty thermostat model. So you'll have some patients that keep it more at like the 72, and when there's little drops, they can regulate like this. And then there's other patients that when they have a little drop like this, they shoot all the way up to try and overcompensate, and then it shoots back down. And so that's, no matter what their airway or what they look like, it's just their body's like biochemical response to the stress of an airway collapse. But to answer your question, yes and no. Men are more predisposed. It's not overwhelmingly more men than women, from what I see.
You mentioned something about your daughter. So
Yes.
Children.
Yes.
Is sleep apnea common in children? Is that something that you're seeing?
So obstructive sleep apnea is not common. It's about 2 to 3%, I believe, is what of true sleep apnea. Now their parameters are a lot stricter. So for an adult, when you register what's called the apnea-hypopnea index, and the only way to diagnose sleep apnea is with a sleep study. A child with 1 can be diagnosed with sleep apnea, where an adult has to start and make the threshold at a 5. So even with those strict criteria, children are very rare to actually have sleep apnea. Now sleep disordered breathing, snoring, grinding, mouth breathing, those that suck their thumb, is very prevalent in children. It's estimated that 9 out of 10 children actually have some sort of sleep disordered breathing. Symptoms of ADHD is very common. Poor performance in school, extended bedwetting, where you're told they'll grow out of it, is not normal. So those are all signs, because their chemicals are doing the same thing, and when they're stressed at night, even though it's not considered an apnea, they have that breathing. So, You know, when I started doing this as an adult, I had met up with a company called Healthy Start that was at one of our conferences, and everything on their banner was my daughter. You know, she had double ear infections, ear tubes, reflux as a baby, couldn't breastfeed, so then went to the bottle and used a pacifier, and all stuff that's, you know, now in the world of sleep is a big no-no, especially the pacifier. But she had all these signs, and she grinds, and you know, you know, everybody wants the best for their kids. So she had tubes when she was younger. She's had a sleep study. We actually went in August because she has very large tonsils, thanks to me, and that can obstruct a child's airway. She does not have sleep apnea, but we are doing early ortho for her and expansion to help make room so that she has room and proper tongue posture and all of that. But yes, she's my my son sleeps like a silent baby, but she's in double expanders now and
wow.
on her way, and she's 6.5.
Wow.
Yeah.
Okay, so diagnosis.
Yes.
What does the process look like? You think you have it, you have issues sleeping, breathing. How is the actual diagnosis process?
So for every patient, like I said before, you have to be diagnosed and treated by an MD. And so if you come see me first, say you came from the dental hygiene chair and there was dental signs that the hygienist said, you know, I think Stephanie, you've got some sleep disorder, and long saying, I just don't sleep well. You come see me, we deem it as we need to go see what's going on. So we can do one of two things. One, I refer, if you have a family physician or already have a sleep MD, I refer you to back to your physician and say, hey, I suspect suspicion of sleep disorder breathing, please evaluate. I've learned in the last few years, especially with what our world has been, that it's easier and more patients are more prone, is there's actually these telemedicine companies out there that have board certified sleep physicians on board. And so I've started utilizing those, and I'm getting more patient compliance, and patients are doing it because a lot of the legwork's done for them. So I would refer you to a company that I use. They would call you and say, all right, let's set you up with Dr. So-and-so for an initial consultation. You don't have to leave your home. It's a Zoom consult with a sleep physician, board certified, and you have your initial consultation. If they deem it necessary, they would order a home sleep test. Most testing done now is actually done at home, again with the last few years, but those devices have become a lot more accurate and a lot more predictable of your normal sleep. An in-lab study, which is why people don't want to go, because they don't want to sleep in the lab, and I've done it with my daughter. It's not that bad, but I get it. Nobody wants to do that. But if you can do it in your own home, we may not get every single data point we need, and the physicians and techs need, but we get a better accurate night of what you actually sleep like. So there's pros and cons to both ways, but you have a sleep test, usually sent to your home. It's like a watch one. There's all different types now. They're very easy to use. I've used a few of them. But you complete the test, it's interpreted by a physician, and then you get the follow-up call, and you get, Stephanie, you have mild obstructive sleep apnea. Once the decision's been made, what treatment you guys are gonna do, the prescription is written. So if it's more severe and it's a CPAP, it's a prescription for CPAP that's sent off to a DME company, and they fulfill that, and then you go that route. If it's back to me for an oral appliance, you get a prescription, and then sometimes we can actually utilize medical benefits to cover that device. We're also considered DME. But you come back to me, and then we start the process to make you an appliance.
Great.
Yeah.
Sounds easy enough.
It's not too bad.
Well, I hope this answers some of your questions about sleep apnea, and hopefully this gives you a valuable resource to help you sleep better.